I want to welcome you all to our 5 pillars of financial effectiveness. We have completed the first 3, which is physician compensation, insurance contracting, and one of my favorites is staff productivity. So today I have a special guest with me that has joined me in our efforts in terms of revenue cycle management. So I will introduce her in a minute, but just want to do a little housekeeping. So again, I'm Steve Febus, the Director of Advisory Solutions at DZA. Look forward to having a discussion. I want you all to be thinking about questions you might have, because we'll have a wonderful opportunity to talk to Nichole here towards the end, but I'd love to get her input in this revenue cycle optimization. So as a disclaimer, and our normal, we are not providing any legal advice. This is just informational, and we want to provide awareness. So is anybody else having any issues? I see one comment already that we're talking, but you can't hear. Are others able to hear okay? You can put something in the chat or page, maybe, if you can let me know. Okay. So Kelly, sorry, others can hear us. Great, thank you so much. Appreciate that. Hopefully, Kelly, on your side, you might be able to get that fixed, but we will continue on. This presentation will be made available to you afterwards. Should you like to have it for whatever reasons, we're happy to provide it. So what are we going to do today? We're going to talk about this whole revenue cycle management, hopefully to demystify a little bit of it. Ideally, I think our primary audience are CFOs, finance teams. There likely could be folks from the revenue cycle team on this. We're happy to hear from all of you, and even things that you've experienced that would be valuable to the rest of us, because we're here to learn together. So we'll walk through various areas of opportunities for you and your health systems, things to think about, preventative ways to provide sustainability, ultimately improving our financial outcome, ways to look at your revenue cycle management intelligence and growing that side of it for you and your team, developing your key performance indicators, how that looks for you. We'll provide various examples. There are so many out there. You want to make sure that they're meaningful to your organization. And then, so I'm going to go back and forth a little bit here. My guest today is Nichole Hunt. She's the president, CEO of Coding Concepts. I've had the wonderful privilege of working with her a couple different occasions, and I'm delighted to know her both on a professional and personal level. She's got so much energy. I find myself struggling to keep up with her. So welcome, Nichole. Great to have you here.
Thank you so much, Stephen. Thank you for inviting me to be a part of this presentation. I'm looking forward to sharing the information with the team.
Awesome. Well, it's a delight to have you here.
Thank you.
So with that, let's start with the basics. What is this revenue cycle management all about? So you think about it, from this patient arrives to they go through our health systems. Hopefully, at the end of the day, we provided great care, and then they're discharged, and we're left with this follow-up with this bill, and ultimately we get paid. We hope. So the whole process is a lot of effort from all the way from that front end to that back side. So within that front end, the area of focus that we're going to talk about is that pre-registration, registration, charge capture. We'll talk a little bit about who's involved in this revenue cycle. And then we'll talk again about middle cycle management, your utilization, your coding, claim submission, areas of pitfalls in which this cycle can get broke. And a little infographic there that we'll revisit is where money begins to fall out from our revenue cycle. How can we fix those areas? So eventually we hit that back in when we actually see the remittance. So that's our area of focus today. So with that, let's just go to the next slide. And I'm going to dive right in. Now, this is, forgive AI, but this is AI's ability to take Steve's thoughts and capture it into this 40-step healthcare maze. I'm thinking, Nichole, isn't really Medicare billing revenue cycle just we saw the patient, we charge the patient, we drop a bill, and we get paid?
That is not the case.
I'm talking
It's so
this revenue cycle stuff.
It's complex. When it comes to billing, I will tell you, I am in the mindset, I've been in the business long enough that, 20 years ago, we would, code a claim, bill a claim, we got paid. Now it's becoming more difficult and more difficult. Within the past 3 years, it's even become more difficult in the fact that we can't even call a payer in most cases. They drive us to their portals. They ask us to fax. They ask us to contact them any other way than calling them on the phone. And then when we do call them on the phone, we may be able to only check the status of 3 claims. Meanwhile, we're sitting here with 53 claims. And that's very stressful to a billing team. So the labor intensive process for just checking a status of a claims becomes so difficult. And then, of course, then you've got the contract end of it. Depending upon your contract, whether you're contracted or you're not, you may, your reimbursement may be 48% versus 95%. So there's a lot of different steps in which it takes to get a claim paid or even out the door, because there's claim edits before it even goes out the door. Then you have your clearinghouse edits that are payer specific. So it's become more complex. So this particular slide is really how it looks and how that process works. Truly, as scary as it may be, these are all the different areas. One other thing that I would like to add is that clinical departments never really used to partake in the revenue cycle experience. And now it's almost that if they don't understand even just a base knowledge of how important and what they do impacts the revenue cycle, then that there could be one of your revenue leaks, because they just don't understand what they need to do to help capture that revenue.
So I have a question for you on that, because you bring up a really good point. So who's involved in this revenue cycle? So is it just the billing? Is it just their, I've been in an organization where it often feels like AR it's billing's issue, when billing is, going, well, wait, things didn't happen on the registration side. That's why we're stuck in this thing. So who's responsible for this?
Everybody's responsible in revenue cycle. Every revenue generating department is part of the revenue cycle. It starts with registration when the patient walks in the door till that patient balance is 0.
Sure.
All along that claims process, every single department has to be engaged and has to be involved. And if they're not, that's where you see those pitfalls.
Sure. Well, I'm curious, and so when you think about the generation of a bill, what are all the components that go into that? and I know we don't have time to get into all of that, but what are the main things? So when we think of, if we can go, I think the next slide, I want to talk a little bit about this team. So as we think about how should you audience think about your revenue cycle management team and your approach. Number one, I heard you just say it includes everybody, and you should own the whole flow. Now, one thing I would highly recommend everybody to do, develop a revenue cycle team. Find out who the right members are for your size organization, and then begin to map these processes. So as you think about that last slide in this 40-step maze, and you go to the registration or pre-registration to even maybe point of service collections, what does that look like, and what is currently happening in your organization? And so that you better understand it. We're working right now in an organization in which they've recently transitioned to a new EMR. As a result of that, just understanding that workflow has been challenging. So, and then understanding the ownership of it. So when we say own the whole flow, it takes the team, but we got to understand what that process looks like. So then there's standardized workflows. How do you really break this down to improve that process so that you have less variability? And at the end of the day, ultimately less denials and improve your cash flow. Ultimately, to then how do we measure this? So I want to start talking about that. If we can go to the next component, and we think about all of those opportunities, let's just do it all, Nichole. Can we go ahead and boil this ocean and fix it all?
It's always going to be something that you're going to focus on, have to work on. It's not a one and done. You don't just set it up and it just works perfectly. It's going to take constant involvement, retraining, and involvement of the team to make sure, because at any point, at any time, it'll break. Today you can bill a payer and they're paying correctly. The next day they're not. And if you're not watching the flow of your data and watching your reports, it can become systemic before you even know that it's an issue. So looking at this daily, having each department accountable for reviewing these reports, where registration, it starts in registration. I require 100% registration review of every registration when it's in a hospital. And the reason for that is because they may touch a lot of different departments. They may get admitted, and those bills could become extremely large in a very quick minute. And if we don't have registration set up with proper insurance, proper demographic information, no matter where that patient goes in that process, that's where it begins to start breaking down immediately. So having 100% registration could be the difference between getting paid for a $100,000 bill or a $5,000 bill, or not getting paid at all. So registration focus and making sure we're getting the correct information as soon as that patient walks in, because from there, the bill just continues to grow.
That makes a lot of sense. You know, when you say that and you think, I think about registration, probably many of us that have been involved in organizing these growths and changes, especially in rural America, and which now we own physician practices at a larger pace than we ever have. And a lot of it is just making sure we have access to care in these rural settings. But my experience is, we have 16 different clinics. We have 16 different ways to do it. Is that a good approach for registration?
It's not.
No.
Registration, it needs to be consistent. Consistency prevents errors. And whether it's, I mean, the difference of that will be is if it's a hospital that has a professional building or multiple clinics, standardization, well-documented policies, procedures, and updates. Payers change all the time. And we get into contracts as hospitals with different payers. And so making sure that our front end team is updated and those consistencies are validated every year, because it changes so frequently. So again, keeping very much standardization amongst your hospital and your clinics is key, because if you don't, that's where the errors occur, and then from there it just becomes a systemic issue.
So now you give me, my wheels start spinning. I start thinking about charge description masters.
Yes.
And who owns that process. You know, you talked about the clinical staff being intimately involved in that. I'm curious your take on how much of that development of like your price strategies, that contract management, how does that play into this boil the ocean? And, you know, what are the key levers that, you know, us in the field are trying to manage for financial effectiveness? What are some of those like key points?
Charge master, that's a good point. Thank you, Stephen, for bringing that up. Charge master is one of the biggest things. When I go into, I do a lot of consulting in revenue cycle and do revenue cycle assessments. And as much as that each hospital is unique. They're not unique in the same challenges that they face, unfortunately, and quite honestly, even with larger facilities. And so you could have the best workflow processes, but if your charge master, which they used to say HIM was the heart of a hospital, but I think it's your charge master, because if everything is firing on all cylinders, but your charge master is not maintained, updated, and monitored frequently, and is competitive, and you're looking at your pricing, and that's a good lead into your payer contracts. Knowing your payer contracts and reviewing those payer contracts on a routine basis could have such a large impact on your revenue. And we're talking swings of today and is paying 95%, tomorrow they pay 48%.
Yeah.
That's how quickly there could be a swing.
Sure.
And then with a charge master, obviously it's their charging system. So when we look at charge masters, we need to look at it from each department. What are we charging for? What can we charge for? And we've got inventory systems. How many inventory systems touch a charge master? What does it look like? Where is the markup happening? And then actually maintaining the charge master. There are quarterly updates that come out every quarter. And it is revising a description. It is changing a CPT code, changing a HCPCS code, all those types of things that come out quarterly. So if we don't maintain that, then what happens is once it gets to billing, it could be claim edit, it can hit a claim edit, preventing it from even getting to the clearinghouse, or even a denial, or a reduced rate.
Sure. So, I start thinking about, you say we, and I'm assuming back to the other slide where we talked about the revenue cycle team, that's the team working towards that, working with those department leaders to understand, because they do have, I personally feel like nobody knows the business in an OR like the OR manager, right? I mean, we can come in, we can tell them, but they're going to tell us what their workflow is and what they're doing. The more we can integrate them into the understanding, the better off we'll be. So when you go into an organization like this, how do you approach it? Do you sit down with departments? How do you educate yourself on understanding where this opportunities might lie?
That's a great question, Stephen. Thank you. So I'll just first preface it by, when you do charge master reviews and vendor selection, because it is the heart, right? It's the heart of your revenue cycle. I caution everyone, if they say, send me your charge master, and then they spit you out a charge master and make recommendations. I know some of the people on the call today, some may be critical access hospitals, you may have RHCs, some of you may have community hospitals. Nobody knows your business like you know your business. So it's really, really important that when you select vendors, if you are a COC, community medical center, you need to make sure that they have the experience and understand the reporting requirements for those facilities. That's number one. Number two is, with the charge master, because it's so complex and we have so many charging areas, when I first go into an organization, and it's a lot of upfront heavy lifting, but I go in and I meet with every revenue generating department. And I want to know what their understanding is of revenue cycle, because some facilities, when you meet with a department, are like, I don't know. I just get a report, because that happens often. Sure. But what I do is I need to find their level of understanding, because what my ultimate goal is to engage every revenue generating department in the revenue cycle. I want them to understand the basis of their part in the revenue cycle. And so they look at things differently. They start looking at supply utilization. They start looking at tracking, because a lot of times when I go into like med surg or I go into the ED, they're like, well, I don't document that because I didn't think we bill for it. And so that happens a lot. And then you start finding revenue leakage from a clinical standpoint. They just don't know what they don't know.
You bet.
Or they're like, I take that out of the Pyxis system and I use it, but I need to use another one. So I take it out of the Pyxis system, or I take a vial out and then I just throw the rest away. I mean, you learn how much loss in each department by just engaging them in the process, getting them to understand that everything they do in treating a patient affects revenue cycle.
That's good. Beautifully said. So let's move on to the next slide. You know, as you talk about this, I think it's really important for the audience to understand, if you look at your financial position and you think about your organization, look at what a 1% or 2% net improvement from your net patient revenue looks like. And I will guarantee you, you're going to have to take the equivalent of 10+% out of your operating expenses to have that same impact. So this is why revenue cycle is so important. And let's break it down a little bit. Just kind of take what you've been talking about, digest it a little for the audience here. So front end, when we start talking front end, there are more stages than the three, but the three major ones in terms of just focus and downstream implications are that pre-registration process. What am I talking about? That's verifying the demographics, making sure we have authorization to do it. We can provide a lot of care with no authorization. We don't get any money. Pretty soon we aren't providing any care.
Yeah.
So bad data on the front side, guess what that ends up being? Denials on the back end. We're going to talk about that in a little bit. I want to get Nichole's perspective. Is denials a four-letter word or not? And so we'll address that here in a minute. But then registration. So the patient actually comes in. What does that standard intake across the health system look like? Should it be different? I mean, there might be nuances to the types of services provided, but overall, there should be some standardization. Payer-specific language. You know, do we understand what that looks like? Have we provided the Medicare patient with non-covered related aspects, and then can we bill for it? So that's part of that registration. And then ultimately capturing those charges. So charge capture drives revenue generation, which is your fastest way to get a dollar to your bottom line. So there are opportunities in that. I would highly recommend. I've had the luxury of having a professional look at a lot of this, but just looking at pulling some claims, having those discussions like you mentioned with the clinical leaders to talk about, oh, I didn't realize, again, I didn't know what I didn't know. So then the next phase is really that middle component to it, which begins to think about your utilization review. And that is your patients here. What's the status? Should the patient continue through medical necessity? What's your payer readiness? Are they allowing you to keep that patient in? So that whole utilization review component, and then your coding aspect. So what was the diagnosis and what did we do? Therefore, how do we code this correctly so we can get paid effectively? Upcoding, downcoding, equally wrong. We can talk a little bit more about that as we get into if that's the right way to go, Nichole. But really, rural hospitals, any coding delays, any weaknesses in documentation, guess what that equals? That means that revenue leakage, that's what we're talking about. So then you claim submission. Finally, after all of this, we actually get a bill. And I'm sure, Nichole, in your experience, that has never been an issue. When we get here, it just goes purely clean, right?
I'd like to say that it is. The processes don't normally, if there's so many ways that a claim can get hung up again. We just talked about a few of them. And I just want to touch on the slide that we have now. Utilization review, case management. If you don't have one, you might want to think of one.
Yeah.
They really help drive status. And what I mean by status is patients presenting the ED. Are they a direct admit? Are they observation? This seems to be the biggest struggle with every hospital,
Sure.
whether it's large or small. But again, it's just arming yourself with a team that can help make decisions that can prevent those denials at the end. So utilization review really helps in that process. They also help, and they're really beneficial. And when I go into small facilities, the first thing I ask for, do you have utilization review? If they don't, I say, let's get one going right away, because they have such a benefit. And quite honestly, what they can handle in a small facility is like all of your infusions, where if you do chemotherapy, if you do immunotherapy, if you do high cost drugs for your admissions, your prior authorizations for all of that, all of those services I just provide for outpatient, your prior authorizations and your reevaluations and prior authorizations for inpatient, and making sure the providers are completing their documentation. They're kind of our police.
Sure.
Before discharge, before anybody else sees it. They're making sure that we have admitting orders. They're making sure that, we're admitting the right statuses. So utilization review is extremely important. They can drive thorough, complete documentation before it even gets to coding. Then coding gets it, and then of course they're having a strong coding team that understands the type of coding that they're coding for. And then when it gets to claim submission, which I know that was a little lengthy there, but I wanted you to understand everything that it took to get to the claim submission. Then again, we talk about, your payer contracts. We talked about clearinghouse. My goal always is to have a clean claim.
Yeah.
So most all EHRs, RCM systems have the ability, and you can do it manually, to calculate a clean claim rate. I want to talk about it real quickly. Why is it important to have a clean claim? Is because it's becoming harder and harder to follow up those claims and appeal the claims and challenge claims. And it takes a long period of time. A payer, generally it's between 45 days, and there are some payers that are saying we're not processing appeals until 365 days. So now you can see what your AR is doing. Now we're going like this, like big dips in your AR. We don't want that. We want consistency, especially in smaller facilities. It could be as much as making payroll in some cases. So preventing that claim from getting denied is what our goal is. I look at a 95 to 98% clean claim rate. I mean, that's taking into consideration our payer contracts. That's taking into consideration that we've updated our CDM. I mean, there's a lot that goes into that. And that's where the true work begins. The processes have to be established, and the monitoring, the maintaining has to happen in order to achieve and maintain that clean claim rate. That's how you keep consistent revenue.
I love that. And it goes right to that final point there about consistently appealing claims, which is going to delay payment.
Yes.
Isn't the place we should be focused. Our focus should be on, let's fix the real issue.
Absolutely.
Documentation, authorization, status review, all of that, so that we aren't delaying these claims getting out the door.
Exactly.
All right. So then the back end, where the pot at the end of the rainbow is when we get our money, right? I mean, that's a good CFO term. And I would challenge every CFO in the audience, understand your revenue cycle. If you haven't been involved and maybe you're newer to the industry, really sit down with the team and get to understand it. Don't sit in your office and just raise your hand on how do we get the money in and pound your fingers on the, fists on the table, but really understand it, because you're an integral role in the development of a good process. So that back end side of it is really that remittance. A lot of opportunities with follow-up. I mentioned denials and the, is it a 4-letter word? I think of denials as an opportunity to understand where our system broke. It doesn't always mean that is, works out perfectly, because a lot of insurance companies today are using AI and actually denying claims that shouldn't be. Now, our issue is in rural healthcare is, do we have the manpower to understand, balance that, and track it? because we leave a lot of money on the table, so to speak, or actually just write it off and throw it away if we're not managing that effectively. And then patient collections. And there are opportunities in that. Can we collect at the point of service? And what does that look like within your community? How do you manage your communication to your patients? So let's go to the next slide here. Back really, Nichole, to you with all of that. I mean, you've touched quite a bit of these already, but what can you tell our really the audience today on this rural healthcare revenue cycle from this front, middle, back end? Where are some of those key things again that we should be focused on?
Well, as I stated before, the front end is key, registration, and then the middle part of that is making sure you have the documentation. Again, your CDM is updated, making sure that we're coding specifically and capturing chronic conditions and those kinds of things, especially when we talk about delaying patients from being discharged and things like that. So and then engagement amongst all the different departments prior to when we get to the back end. The back end, really, if the front end processes we have in place, if we can maintain them, keep up on them, monitor them, then the back end also has that. Once we push the button, clean claim, beautiful. When the denial comes in, we learn from our denials. This is the biggest area that has grown tremendously and can be the biggest burden for revenue cycle. So not just maintaining and monitoring everything from front end, middle but now in the back end, from the denial end, is that denials come in. It's an opportunity for us to learn. It checks us. It checks us for pricing, it checks us for payer contract potential, renegotiation. Also, there's other things that are even more complex, is that payers are trying to bundle everything. And when you hear bundle, don't be too frightened. But what they're saying is, you do all these services. We really only want to see one line item. We want to see a room rate, everything bundled into that. And it's hard for critical access hospitals and community hospitals, because this is where it can break a small facility, is because they're wanting to reimburse us on IPPS and OPPS. So when we say bundled, we have to fight for those contracts. We have to fight to carve things out. If we provide chemotherapy, we need to carve certain things out of our contract that are high cost services that we do, that we need to have carved out in our contracts. Because if not, then what we see on the back end is denials. We see high contractuals. So even though we bill out $100,000, if we only get in $250,000, we have work to do. Sure. We have to be monitoring our denials just as much as we monitor until it becomes a payment or a contractual. Yeah. And then those contractuals, we need to keep an eye on the contractuals, because just as I stated previously, is that we may have a contract with a payer and they're going to pay us 85% of billed charges. Like I said, one day they do that. The next day, they may not. And watching the denials and keep preventing, if you will, being proactive before it becomes systemic is extremely important. So I look at every single contractual. I want to know why it's a contractual. I compare it to my contracts. One thing I can say, and AI is one topic that I know Stephen's going to bring up today, if you're not looking at it, start thinking about it. Where would we benefit from AI? Mm-hmm. It's, in my mind, AI is not going to get rid of a human touch. Sure. But what functions within the revenue cycle would benefit from AI? And the way I think about that, if we can develop simple logic, and when I mean simple logic, I'm talking about on the back end. Mm-hmm. When we get a denial from a payer that says need medical records, let's teach AI to say, oh, this needs medical records. It's one function. It's not that it's going to come back and it needs something that could mean 15 different things. If it's something as simple as that, AI can understand that. Medical records, it can attach that last visit to that record and automatically send it out. So what this is doing, and especially in small communities and community hospitals, everybody's wearing multiple hats. So we're trying to decrease the heavy work burden so we can focus on those that really require a human touch to resolve. So
Yeah, it makes sense. In fact, ran into that this week, working with a local insurance company, and they had requested a record, and now we're 6 months later, and all they wanted was an H&P.
exactly.
But now that accounts receivable has sat there for 6 months, waiting for something as simple as an H&P.
Exactly.
And that could have been done, claim adjudicated, money in the door, and we move on.
Absolutely,
So-
100%, especially with those work comp carriers
Sure.
and your MBA. They have very short windows. Usually their timely filing is going to be anywhere from 90 or 60 days to 90 days to 180 days. And so again, we're wearing multiple hats, and if we're in a facility and we're processing a lot of claims and we have a lot of denials and we have minimal staff and we have 3 FTEs that are vacant and we live in a rural area and it's hard to recruit, anything that we can do to automate is something we should focus on, especially if it's going to have a large impact to
Yes.
our accounts receivable.
You know, something on this slide, I just want the audience to see, it's in the middle box. This is really important for your team to understand. Insights and feedback are extremely important. I have experienced way too often in my career, we versus they internally, where we are fighting against each other when really it's all us. And I really try to demystify that. I try to get the team in the same room to talk about, we're all working together. Let's talk. When billing brings up an issue, we shouldn't get defensive if we're registration, or vice versa. If we're working on coding and something isn't, it's not a coding issue. It is maybe it's a registration, maybe it was a billing function. Don't get frustrated with it. Just work collectively to solve it. So let's move on to the next slide. So we talked a little bit. This is a little busy. I get that, but I wanted to talk about these various payer. You mentioned something on timely filing. What the heck is timely filing? I mean, and what should we do? I mean, do we need to keep track of what we did?
Absolutely, 100%. Timely filing is the duration in which you have to get a claim to the payer. And if you don't get it in that time frame, they will not pay the claim. It's just 100% denial. Now, some payers, you can actually appeal that and they will be overturned. But I will tell you, more so now, within the past probably 18 to 24, 28 months, payers are just saying no. It's their way of keeping the money. And so it is very important. In fact, the facility that I'm working with now, that was one important point that I wanted to do. Your workers' comp, your MBAs, all of those MBAs, all of those payers that have, other than a 365, I put those into a priority work queue.
Sure.
I put them in priority work queues for every single part of the claim process. So if it's the providers, I put it in a specific queue saying this is a priority. I only have this much time. Because now, I mean, if you have a patient that's discharged and you have a 3-day hold, 5-day hold because you're waiting for charges to come in. Okay, so we're 5 days down.
Sure.
And now we have to get it through this whole very complex revenue cycle process that you've seen on previous screens. So we look at that and we think about it and say, 60 days is not that much, but 60 days can be a lot if you have a complex system.
Sure. Yeah.
And that you don't have a good workflow. So it may take 30, 45 days to get a claim out the door. You never want that.
Yeah.
And so I prioritize those that have a short timely filing. There's one other part to that is timely filing. Whether it's 60, whether it's 90, whether it's 180 or 365, there's other ways around that. So if we've billed a claim and they've denied it, the importance of working our denials is key. So what I'd like to share with the group today is if you have the ability within your revenue cycle platform and or you have to pay for this module, it's well worth it. It's called a contract management module. And what you do is you load your payer contracts into this module, and you load in what the expected reimbursement is of these contracts. So at the time of posting, you want to get those appeals out as quickly as possible, because again, then you're running against a timely filing right there.
Yeah.
And so even though you send the claim out, when you get the denial back, you're on a time schedule to get that claim appealed so that it can be adjudicated, or you lose it.
Makes sense. And clock starts to tick.
Absolutely.
Yeah. All right. Well, we're going to continue on. So far, this has been fabulous. I really appreciate it. So let's move to the next section here. Talk a little bit more about what are those key levers. This slide is actually just intended to say, maybe in your organization, it might be charge capture audits. Maybe it's denial root cause analysis. So for you in your organization, it's really understanding your prioritization. Again, back to not trying to boil the entire ocean at one setting. What are those things that are going to have the most impact for you and your organization? So that is your next steps. That's your assignment to understand that. If we want to continue on to the next slide, let's do so. So I believe this, getting close here, we're going to wrap this up. I want you to be thinking about any questions you might have. You can start populating in the chat. That'll give us an indication that we hit the primary subjects. I think we got a couple slides in terms of KPI development, but revenue cycle. When we look at this slide and we look at these areas where we have holes in our system and we're losing money, what are some experiences like you already probably touched on, like the payer underpayments, understanding that contract module, timely filing, but anything we've missed so far, Nichole, that you can think of?
The only other thing that I would say is once you stabilize your system and your process and your workflow, setting KPIs are important. And setting KPIs, like Steve and you have talked about multiple times, it's not about just reporting. It's those key performance indicators so that you can monitor and maintain and measure what you're trying to achieve for your facility. As an organizational level, you can set KPIs, but even at the department level, and when I go into the department, because I've been the interim HIM director or interim revenue cycle director for many hospitals, and I always say less is more, because when you set KPIs, you want to be able to make sure that you can meet those KPIs. And if you can't, then you need to find out what you need to do to meet those KPIs. And then once you meet those goals and in its standard, then you do set stretch goals. I always set stretch goals, exceed them. If after a period of time, one of your KPIs, you're not gaining or gleaning much from it, then set a new KPI.
I love that. Let's go to the next slide. I actually think you just hit it. So these are some examples. I would highly recommend that you look over the list. There is a plethora of various KPIs. Do not pick them all. Do not report them all. Pick 4 or 5 that is your primary area of focus. Some of these should be daily. What is my AR? You should be looking weekly. How is the aging of my insurance buckets? Is there a problem? Is that pointing out a situation? Operating margins. Probably don't want to do that daily. You'll never get out of your office. Maybe that's more monthly or quarterly. So the frequency is really dependent on the KPI you're choosing. Here are some examples, but again, like Nichole said, it's really measuring the ones that are important to you. When your system improves, maybe you drop one off and you add another. I will tell you this, for data's sake, don't just measure and do nothing with it. If you're doing that, go golf, go do something else, because you're just wasting your time. Go do something fun, but measure it to make an impact on that.
Absolutely.
All right, let's move on. I think we're getting really close to the end. I'm going to keep these in here. This was if we ran out of time. And I had some other follow-ups. I think Nichole has said much of this. So let's go to the key final takeaways, and then I'll want to open it up for any questions. So your key takeaways: revenue cycle management is an organizational workflow. It's not just a certain handful of people, it's everybody.
Yes.
Use standardization. Start to look at what are your highest leverage points. Let denials and dashboards guide you. Don't be afraid of them. Denial is a diagnostic tool. Use it for your advantage for this intelligence, this growing your financial and payer and revenue cycle management intelligence, and then develop ways to track it. So with that, I'm going to look in the chat here. Paige, I'm not sure if we can open up the mic, but we will entertain any questions you might have. And of course, we have one more to go next month, and that is financial effectiveness. And I threw in there a little bonus of AR health. If we're in healthcare, let's manage our own health. So with that, any questions that you might have. Oh, I do see, Steve, you asked a question. You missed the first three. Yes, those are available. I think we can provide you with the links to that. And then also, you all have my contact information. If you ever have a question about any of the series so far, please reach out. I'm happy to answer those. I know a lot of people that have a lot more knowledge than me, as you can tell. I really appreciate the opportunity to have Nichole here. Thought this would be a little bit different than you listening to me. I get bored of listening to myself as well. What a pleasure, honestly, Nichole. It's always a delight. I always learn so much from you. She's so high energy. I'm usually trying to catch up. So really, any questions from the audience? Again, one last chance, and then we'll give you back the rest of your day. But really appreciate you taking your time to join us, and definitely appreciate you taking time out of your day to join me in this venture on revenue cycle management.
Thank you, Stephen. It was a pleasure. Again, if there's questions, even after the webinar, if you want to send them to me, I'm happy to answer any questions that anybody might have. If this is something that you think is of interest, please contact Stephen, and I'm happy to help and willing to do another if need be.
Yeah, that's so nice. And again, we're definitely have been in the industry a little while. Seasoned, I guess, is the right phrase to say. I'm old, but at any rate, appreciate you joining us today. Thank you, everybody, for your time. We'll look forward to the fifth in our 5-part series on financial effectiveness. Appreciate it and have a great day.